And then now I would like to introduce you to Professor Bhutta. Professor Bhutta is a very distinguished speaker and researcher in the subject of child and neonatal health on a global level. He is the co-director of the Sick Kids Center for Global Child Health in Toronto, and also the founding director of the Center of Excellence in Women and Child Health in the Aga Khan University in Karachi. And as far as I read your CV, you also did a PhD in the Karolinska. So you're home, more or less.
I am, absolutely.
We're very honored to have you here as a speaker.
Well, thank you very much, and I'm absolutely delighted, thrilled to be here, and I had many reasons to come to Stockholm. But before even my association with this university and campus, my very first clinical exposure after graduation was with the MSF. So this is a bit like coming home, not just to an MSF-led meeting, but to Karolinska, where I spent a fantastic few years doing my PhD. I'm trebly thrilled to see my mentor, Bo Lindblad, in the audience, who was both my boss and my friend. And imagine that my midterm defense for my PhD, as I was telling Mats, was on neonatal sepsis in Hugo Lagerkranz's hands. So you know, I'm back on familiar territory. So great to have this opportunity. My talk will be largely around the perspective of where we see the challenge of newborn serious infections, quotes unquote sepsis, in the global context, both from the burden, its reduction, challenges, opportunities for prevention and treatment. What I would like to cover in the next 35 minutes or so is to look at the epidemiology, some of the risks as we understand, mainly focus on preventive strategies because it makes sense, and I'll tell you why, but also cover some of the recent advances in management from a public health perspective that we believe will make a difference in terms of neonatal survival. But let me start by first showing you one of the most influential infographics that was ever made around the field of child survival. And some of us who got together some 13, 14 years ago to drop this global map of where 10 million children were dying every year, saw the world as you see it over here. Each one of these dots represents a cluster of 10,000 deaths. Most of these deaths, we estimated at that time, were occurring in sub-Saharan Africa and South Asia. South Asia, because of its population density, appears as a blur. And from the context of when this was drawn, the major global targets were around the Millennium Development Goals, which have just closed last year. And of the Millennium Goals, although there were 8 of them, very few remembered any other than the 2 core goals around maternal and child survival. And the child survival goal, goal 4, was to reduce global child mortality by 2/3 compared to a 1990 guesstimate, and maternal mortality by 3/4. Now, in 2016, as we look back, the world has done phenomenally well. Because from an estimated 12.7 million child deaths under 5 in the year 1990, we were able to reduce child mortality to figures of around 5.9 million deaths, higher than the global target of 4.2. But if you take population growth into account, the world potentially met the Millennium Goal 4 target. And this, friends, was the fastest and the most dramatic reduction in child mortality in the time span in the history of mankind. And it's occurred largely in front of our own eyes because of the collaboration, because of the work that many agencies did together. And MSF also had a very significant contribution to this. But the success was not equal. So if you look at the world again from a map of where this mortality reduction took place, you'll find that while there are many countries that have had fabulous rates of reduction of 5% or more, Southeast Asia, China, the Brazils of the world, parts of the region that you see here, many had much less, and parts of Africa and Asia fell behind with rates of reduction which are less than 2%. And that's why it's not game over, that it is not mission accomplished, that we still have a huge challenge in terms of reducing child mortality, of which a major area of note is newborn survival. So if you look at the rates of reduction, while the slope for child mortality appears quite dramatic, as I've shown you, for newborn mortality is much less so. And that's why, as we speak, neonatal deaths account for close to around 45% of all under 5 deaths globally. So if you look at the etiology envelope of neonatal mortality, it differs somewhat by regions where you have high rates. So you heard today as to how in regions where rates of neonatal deaths are more than 30 per 1,000 live births, the principal major killers are what used to be called asphyxia, prematurity, and serious infections, of which sepsis is one piece. But one thing that these figures hide are that case fatality rates for some of these disorders, just take sepsis as one, differ enormously between geographies. That in some of these high burden, high mortality areas, the risk of dying with neonatal sepsis is about 30-fold higher or thereabouts than compared to other geographies. These are extremely important things to underscore from the context of understanding risks, because you're not going to be able to tackle this with just therapeutic strategies. Now, the risks in many places are related to the environment. What I'm showing you here is a typical squatter settlement, an urban slum in South Asia. In many rural populations, situations are comparable or worse. So if you look at the risk factors associated with serious neonatal infections, they are the usual suspects that people have spoken about today. In one such review that we did in Pakistan some years ago, you'll find that almost everything that you've heard about today appears. Being born at home in unclean environments, facilities which have less than perfect sterilization procedures and high risks of hospital-acquired infections, the combination of prematurity and morbidity, and importantly also what you do with these babies after birth. And in series after series, these risk factors appear in varying proportions depending upon what you're talking about. But there are relatively few population studies that have looked at mortality patterns in relation to timing after birth and some of those risks. And this is one such series from Shivgar by Gary Darmstadt and colleagues, where he looked at the timing of cause-specific neonatal mortality in community setting. And you will see that these are cumulative data, so you can see that most of the major categories of newborn mortality appear. But for sepsis, one thing becomes very clear, and that's about 40% of all culture-proven episodes of bacteremia in these newborns occurred in the first 72 hours, indicating that there was perhaps a relationship with risk factors that may occur within the mother. If you particularly look at the combination of prematurity, for which an important predictor and risk factor is maternal infection in some settings, then it becomes even more clear. So if you take the global envelope of neonatal mortality, we know that close to around a third of all newborn deaths are related to prematurity. But smallness in size and prematurity in some indirect form lies behind almost half of all of these newborn deaths. And until recently, we were not able to disentangle some of this smallness from prematurity and other etiologies of being small. So in technical terms, because we measure this in terms of body size as opposed to gestation, very few places at scale have the ability to look at gestation in population settings. So there is very little epidemiological differentiation between two types of babies who may appear the same birth weight. So a baby like this, who is clearly premature, may, in epidemiological terms, if you look at birth weight categories, be the same as another one who's more mature, but very small for gestational age. Why is this important? It's important not only because risks of adverse outcomes are very different for the two categories, but what people had not appreciated, particularly from contexts where maternal malnutrition is very common, is that both frequently coexist. That you have both prematurity and growth retardation in a significant proportion of cases. And why does it matter? Because when we looked at this and published this as part of our Lancet Nutrition series, just look at the differences in the relative risk of neonatal mortality based on whether or not you were term and small for gestational age, just preterm, or preterm and small for gestational age. And in this particular category, irrespective of whether you were born in Africa, Asia, or Latin America, your relative risk of dying was between 16 to 30 folds higher. So that's the subcategory where even though small, a lot of disproportionate mortality clusters in the newborn period. I want to talk about yet another risk factor for neonatal infections, both in terms of preventing it and also increasingly apparent in terms of optimal management of some of these babies. So when we looked at this in the context of breastfeeding risks and young infant mortality under 6 months of age, a gradient appears, which is very clear, and it's been shown in both of these meta-analyses. So compared to predominant breastfeeding, partial breastfeeding increases the risk of mortality, either due to diarrhea or pneumonia or all-cause mortality, by about 2 to 4 folds. But if you were not breastfed, then your risk of dying increases virtually exponentially to 10 to 15 folds. What we also know is that it's not just the absolute risk of dying in relation to breastfeeding in the first 6 months, that you have some of these risks clustered in the newborn period also. So if you look at the timing of initiation of breastfeeding, which was an observational study by Karen Edmonds and Betty Kirkwood in Ghana, the fact that you did not initiate, and they took reverse causality into account, that if these babies were not given breast milk for one reason or the other, the associated increased risk of neonatal mortality was 2 to 4 folds higher for those who did not have early breastfeeding. And now it's important to recognize these commonsensical associations, because this does impact outcomes not just in the newborn period, but also in young infants. And yet, if you look at the global reality, and we've just revisited this as part of 6 cohorts as part of the MALID studies, in region after region after region, in some of the poorest parts of the world, the proportion of babies who initiate early breastfeeding is no more than 50%. Half do not initiate early breastfeeding. And if you take exclusive breastfeeding as a marker here, between 1 to 5 months of age, then we fall below a third. Our estimates in terms of exclusive breastfeeding at 6 months of age are no more than 20%. And this is impacted by a huge number of factors: poverty, policies, employment, multiparity, but it's a ground reality in many countries. So let me now turn my attention to what I really wanted to talk about, is solutions. So what works? What can work for neonatal infections in this scenario where such a big global proportion of the burden lies in this age group and in relation to this problem? So to understand this, one has to have a conceptual framework that looks at risks associated with susceptibility, exposure, and also once you've been exposed and developed serious disease, what can be done with it on the pathway to mortality. So not surprisingly, your modalities of intervention are preventive strategies that relate to environmental conditions, especially if they are associated with bad hygiene, with things that I've just spoken about, like nutrition and exposure, and also appropriate therapy. And increasingly, we're becoming aware of the fact that none of this is enough, that it's also important for these interventions to have delivery platforms. How do you scale these up? How do you get these interventions up at scale? And if there is time today, then I'd be very happy to speak about some of the innovations around task shifting and community-based strategies that can make a difference here. Now, to answer the question that I just illustrated here, why are we so focused on trying to get preventive strategies up there? Not just because that it is less expensive, that it is cost effective to put preventive strategies up there. But the reality is that in this day and age, we just can't do enough with treatment alone, at least not for neonatal sepsis. So I wanted to show you data from Pakistan from a sequential case series that we did on looking at trends for mortality. And neonatal sepsis, even with the best management, even with the institution of intensive care in facilities, we got stuck at case fatality rates in series after series of about 16, 17%. That irrespective of the availability of ventilation, irrespective of the availability of tertiary care, expensive antibiotics, that's the case fatality rates that you deal with. And as you saw from the preceding speaker, that in some instances, case fatality rates can be much higher than that. We've just published these data in the Lancet last week, where we looked at a range of situations. And even if you exclude multi-drug resistant infections here, but you take culture positive and sepsis overall, we are looking at case fatality rates in culture proven bacterial sepsis of around 40% in some of these facilities in India. So it is a problem that is very difficult to manage once it occurs, just because of the lateness of presentation, and also because some of these pathogens are now drug resistant in many instances. So it makes a lot of sense to put preventive strategies in place. So let me quickly review what those preventive strategies are. The first simple intervention that we absolutely have to scale up now is the use of clean birth kits. They work, and they work in settings when they are used at scale. So these are data from the review by Wendy Graham and colleagues a few years ago, where she looked actually at evaluation. There are very few studies have evaluated mortality impacts of this. But clean birth kits, if provided at scale and used, reduce both mortality and morbidity, both for the mother and newborn. And the effect sizes are huge. We looked at this ourselves in our interconnections work, where we looked at studies that had used birth kits and measured both maternal and newborn outcomes in the same studies. And if you look at those, we find that overall, they reduce the composite outcome of maternal and newborn infections by about 80%. So they work. And therefore, there should be no birth taking place anywhere in the world without a clean birth kit being available. There is also the issue of risks that are associated with maternal infection. So if you have an obvious clinical presentation with something that has an associated significantly increased risk of mortality, and one of those is preterm premature rupture of membranes, the evidence around the benefits of antibiotics in those situations is incontrovertible. These are data from Kenyon's most recent Cochrane update, where you can see not only is there a reduction in the risk of preterm birth, but also a 36% reduction in maternal chorioamnionitis and neonatal morbidities having gone down by about the same proportion. So 1/3 reduction. And if you look at composite outcomes again, and looking at benefits both within the mother, chorioamnionitis, and neonatal infection in the same studies. So these are not different studies. These are same studies that have measured composite outcome. You can see that overall, we were able to confirm a 1/3 reduction in composite outcomes, benefits for the mother. So this is an evidence-based intervention that should be placed in every facility and can be instituted by less highly skilled care providers. Cord care. For decades, the WHO recommendation was dry cord care. And application of anything to the cord was considered unnecessary. Now, some of us have been involved in community studies of treatment in situations where births are taking place in unclean environments, particularly in community settings. And one such cluster randomized trial was in rural Sindh, undertaken by my group in one of the poorest districts of Sindh called Dadu. And the intervention was very simple. We added chlorhexidine in a cluster randomized trial. It was a factorial design to birth kits with instructions to families that they would apply the chlorhexidine at birth, generally by the birth attendant, and then they would continue to apply it until the cord dropped off. The family did it, not the healthcare provider. And the results were phenomenal. I mean, they're far beyond what we expected in terms of outcomes. And we were able to show that not only was there a reduction, massive reduction in rates of cord infection, but mortality, neonatal mortality dropped substantially. This wasn't just our experience. This was also the observation in 3 large cluster randomized trials of community management of chlorhexidine, albeit there were differences in all of those 3 trials, but when you look at the data together, the reduction in terms of all-cause neonatal mortality was quite substantive, about 23% reduction. And when we did an IPD, an individual subject data analysis of the chlorhexidine experience from South Asia, you find that there is absolutely no comparison. That chlorhexidine application to the cord, either as a single dose or as a continued application after birth, makes a difference. Now, there are now studies in Africa where chlorhexidine has not been found to be effective. But the difference between those studies and the Asian studies are that the studies in Africa are in hospital settings. A large proportion of those births are in facilities. You wouldn't expect chlorhexidine to be effective in circumstances where the birth is clean in the first place. So you have to look at context in terms of where you should be using this as a part of a community strategy. Now, I've talked about breastfeeding as a risk. Is there evidence that breastfeeding makes a difference in terms of actual interventions? The answer is true. Yes. So early initiation does reduce neonatal mortality. Both breastfeeding and bottle feeding in terms of rates of neonatal infections indicate absolutely that breastfeeding protects against mortality. And quite a significant reduction in mortality from studies where those comparisons have been made. But I want to make one point in terms of the benefits of breastfeeding in relation to not just exclusive breastfeeding, but even partial breastfeeding. And that's the key message to get home to pediatricians and practitioners in facilities, that even if you don't have enough breast milk, but give it nevertheless, because there is a benefit, there's a gradient of benefits in terms of both neonatal survival and beyond. And therefore, I get personally very upset when I see that there is artificial formula available in facilities where comparable efforts in terms of getting either the maternal or donor breast milk have not been made. Now, there's been enough on Kangaroo care. I'm not going to speak about this in any great length, except to make one point. And that is, I agree with the notion that the principles behind Kangaroo mother care or skin-to-skin care and neonatal benefits rely upon some of the physiological benefits that accrue from that closeness and the reduction in many of the risks that we have talked about. And there is therefore no single biblical way of doing it. It depends upon cultural and societal context as to how you apply those principles. So if you are in rural Afghanistan or in rural Pakistan, where women will not have access to male care providers for cultural reasons, I mean, there are ways of implementing the principles of keeping the baby close to the mother, co-bedding and breastfeeding on demand that will give you comparable benefits to trying to do it in a very protocolized way. So I've just finished a randomized trial of Kangaroo care in the city of Karachi in 4 hospitals, where we applied some of the same flexibility. And guess what? In timed measures, if you have breastfeeding on demand with small babies with their mothers, they get almost the same skin exposure as you get with classic KMC. So all I'm making the case for is that there isn't a formula. The principles of Kangaroo care rely upon the baby and the mother having that close contact, and particularly promotion of early and exclusive breastfeeding and co-bedding of the mother. The evidence from the most recent update of the KMC Cochrane review show you very clearly that the benefits in terms, as was said, in reduction of severe infections and sepsis are huge, about a 50% reduction in that. And you can see that the pathway to a lot of that is also from about 20% increase in breastfeeding rates in those populations. So it all makes a lot of logical sense in terms of implementation. So as part of our Global Newborn Action Plan, we made a number of observations on what worked, both on the basis of the kind of evidence that I've shown you, and on the basis of what could be achieved at scale. And we talked about these contextual background things that you need to do here, intersectoral living conditions, education, community strategies, outreach strategies based in primary care settings, and facility-based care. And we made the point that if implemented at scale, that could make a huge difference. You could save about 70% of all newborn deaths that are taking place today. The impact of this, both in terms of reduction and what caused those reductions, has also been quantified as part of the Global Newborn Action. This is what we did and published just a year and a half ago. So if you look at what works for infection-related newborn deaths, they range from everything that I've talked about: breastfeeding, postnatal practices, visits, improvements in maternal nutrition to reduce low birth weight, and also appropriate case management. And they can make a difference, certainly, if implemented at scale. And it depends upon which particular context you implement them in. So the point that we drew from our model of what would happen is that although a bulk of this mortality reduction would take place by care during labor and childbirth, but a substantive part was also related to the care of small and sick babies afterwards. So it's a balance between what needs to happen in community settings and also what needs to happen in facility settings. And that brings me to the major challenge of what do you do about newborn care in poor facilities and in facilities where you have problems with human resources, with infrastructure, and also with equipment that may or may not be optimal for the kind of care that you need to give. So I don't want to give you an example from a field hospital. I want you to see the example from my own university teaching hospital, where I ran a neonatal intensive care unit, a level 3 unit for 20 years. And that's the Aga Khan University Hospital in Karachi, where we ran one of the only level 3 units in the country. And in a city of Karachi of the size that we have, 20 million population, we very rapidly ran into problems. So these are data from the period between 1987 and 93, at the peak of operations in this neonatal unit. We're just looking at crude data by birth weight categories. We found that we just could not cope. That if you had babies who were born under 1,000 or 1,250 grams, they were staying in hospital for a month and a half. This is their median stay. And what it meant was that I did not even have space for our inborn babies, leave alone those that needed to come from outside. I did not have enough nurses. Half of the nurses that our nursing school was training were being captured by UK, Canada, and United States. So what did we do? We didn't close the unit. We came up with an innovation at that time, and the idea was, why don't we try and create, in this tertiary care university hospital, a mother-baby unit. This is now the 10th anniversary of the publication of these data. You can read the paper in the BMJ. But we created a mother-baby unit, which we piloted in '93, where the idea was that as soon as the baby was off the ventilator, stable for 12, 24 hours, the baby was transferred to this mother-baby unit where the care was provided by the mother. We had one midwife who was looking after 6 babies. At the time when this concept was put forward, the people who were the most vocal opponents of this were actually the nurses themselves, even though there were so few, because the theory was that this would be malpractice, that this would cause huge problems and medical legal risks for the hospital. So it took me a year and a half, and it took Bo Lindblad's blessings to say this can't go ahead. So this mother-baby unit was started. It still exists today, so you're most welcome to go and see it. and the rest is history. So I'm going to show you data that we published at that time from our experience. Now, admittedly, some of these preterm babies were the preterm babies of the kind that I just told you about. They were both preterm and small for gestational age, given the average maternal nutrition status, but they were under 1,500 grams anyway. So if you look at, and by the way, these mothers just didn't do simple observations. They did everything that a nurse is supposed to do. They were taught how to take temperatures. They were taught how to change the position of the babies. They were taught how to do orogastric feedings, which is what we typically did more than nasogastric feeding, and simple physiotherapy and procedures. And they were the best nurses you can have. So I can give you stories after stories where the mother was told, if the doctor doesn't wash his or her hands, don't let the doctor touch the baby. And I was told, they didn't know that I'd washed my hands just before. Well, go and wash your hands. So they were the most vicious and the most motivated nurses. So what happened? Firstly, for babies born under 1,500 grams, this is not a sanitized data set, our mean weight at discharge was successfully kept at under 1,200 grams. We were able to send these babies home. Not only did these babies actually survive at the same rate as we had before when they were staying in for a month and a half, their developmental outcomes and survival at home was fully comparable, if anything better. But then something else happened that I never anticipated. You know, most of these things are serendipitous. You don't know them until this happens. And this is what happened. Our nosocomial infection rate plummeted like anything because we did not have congestion in our neonatal units anymore. So I'm pleased to tell you that even though now we have a neonatal intensive care unit at the university hospital, which is about 3 times the size of what we had, the mother-baby unit, if anything, has been expanded because the concept of getting mothers engaged in their baby's care before the baby goes home is not alien to common sense, and mothers love it. And guess where a randomized controlled trial of this approach is being undertaken right now? Not in the South, in Toronto, in Canada. Right opposite where my office is, because this is a concept that also makes common sense from a cost-effectiveness perspective. There is one other innovation that I will mention, which relates to those of you who are practicing neonatologists and deal with small babies would recognize that a major portal of entry for infections in some of these babies relates to skin damage. You try and put 4 IVs on a baby and a tape, and first thing that you do is you take the skin off. So one of my nurses, not a physician, one of my nurses, and she's published this now, undertook a randomized controlled trial in an ICU, not in a community setting, in the neonatal ICU of Aga Khan University Hospital, of coconut oil application in babies. And she did an RCT to show the impact, to look at the impact in terms of neonatal outcomes and survival. Overall, the data from the use of appropriate emollient therapy in these circumstances suggests that it has a beneficial effect on mortality, principally through a reduction in hospital-acquired infection. Rehana Salam has just compiled the data on bacterial etiology in some of these infections, which show that it's gram-negatives that go down as part of this approach. So lastly, let me turn towards the real issue of what do we do in the geographies that you work in. It's very easy to do all of this in theory, but in difficult populations, particularly in humanitarian contexts, in facilities where some of these therapies are not possible, how do we approach this? And to give credit to the World Health Organization, based on a lot of noise around home therapy of neonatal sepsis, they organized, in my opinion, one of the best systematic assessment of this research question. So the question really is, if admission and facility-based management of neonatal sepsis is not possible, if hospitalization is not an option in the classic context. So, you know, hospitalization in the classic context in a humanitarian situation, in a conflict area, is now increasingly difficult. You want people to have least exposure, and you don't have the facilities where you can keep babies in for days and days and days. So the question was, is there effective therapy that can be done in ambulatory settings where babies with suspected serious bacterial infection or proven serious bacterial infection can be provided treatment? So this was the objective. It was designed in program settings across various countries, cluster randomized trials, where clearly you had the option where 6 young infants were evaluated by trained health workers using standardized protocol, thought to have possible serious bacterial infections, and then offered referral. We had to ethically offer referral to everybody. And where referral was not accepted, then as a next stage, they were then randomized to an evaluation where they had simplified antibiotic regimen. And you can read these papers to get the details. If they were critically ill, there was no ambulatory management. They were transferred by force to a facility. But those who had clinical severe infection and fast breathing received these alternative regimen. To cut a long story short, they were admitted based on standardized criteria. And as many trials have, there were some exclusions which are also mentioned here. The studies were done in 5 countries. 4 have been published. 1 is under publication right now. So the African studies, the Afrinest studies have been published. The Bangladesh trials also been published. And they were not small. If you look at overall, we are looking at populations of 100,000 and births which were close to around 20 to 30,000 per site. Results. Let's look at the fast breathing results, which are perhaps a little bit shaky, because fast breathing may or may not represent pneumonia, but this was the protocol. In fast breathing, you clearly see equivalence. The other one, which is clinical severe infection based on the criteria that I mentioned, again, you see absolute equivalence between reference treatments. So the simplest simplified regimen that you had in comparison to these 14 injections, which were oral amoxicillin, gentamicin, and procaine penicillin, showed convincingly that just giving oral amoxicillin and gentamicin in these circumstances did the trick. And that meant that you could have field workers treat neonatal sepsis in those kind of circumstances quite effectively. Now, WHO has gone on to now develop these guidelines that have been formulated, and there is a referral protocol and algorithm that is there for people to operationalize, and studies are going now on implementation of some of these guidelines in field settings. My last point relates to what was said in the preceding talk, which is the emerging issues with drug resistance, and this we cannot take lightly. So I just want to show you 2 slides from my own university hospital in terms of what has happened over time with, and these are obviously hospital admitted children for 2 organisms, 2 sample organisms, Klebsiella, and you can clearly see drug resistance has climbed, both multi-drug resistant, and you see this with E. coli also, both partial and multi-drug resistance. The impact in terms of mortality, and this is a comparison now of survival rates between drug-sensitive bacterial infections and drug-resistant bacterial infections. So unlike what's just been published in Lancet Global Health from Delhi, from India, these data show very clearly that overall there is a 5-fold increased risk of mortality with all treatment being available, with all supportive management in those babies who have antimicrobial resistant infections. So we as a global community have a huge challenge, both in terms of prevention and also in terms of ensuring that our bacterial treatment protocols in hospitals are rotated in such a way that we can reduce the prevalence of nosocomial drug-resistant infections. Easier said than done, but it has to be done. So let me finish by this real story. This is a woman who, in the middle of the floods of Sindh in 2010, I was asked, as part of the team that was there at that time, to see this baby. And I went to see this baby. You can see that this baby had been screened by the physicians, He's thought to have an infection. He's got a cannula in there. And I looked at the baby. The baby didn't look too bad, but the mother looked like death. And she had walked that day with a 2-day-old baby 11 kilometers to come to this facility. There was no space. And she was lying on the floor with this baby, and nobody had seen her. Why? Because they were focused on the baby. So one of the points that I want to emphasize absolutely is that there is no treatment for neonatal infections without including mothers in the equation. So we should be increasingly looking at the mother-baby dyad. And for all of these protocols for prevention and management, one has to have a clear management prevention framework that includes the mothers in the equation. So strategies that we have available today for prevention and management of neonatal infections are not rocket science. They don't require a lot of resources. They require a philosophy and an approach that's based on best practices and the most cost-effective management and assessment of these babies. Detection and management of malnutrition in the mother before childbirth, rapid detection and institution of treatment for infection, prevention and care of these babies, which includes also assessment and breastfeeding, and importantly, the appropriate institution of antimicrobial therapy and follow-up in these babies. Thank you very much for your attention.